But we have a couple questions, so I'm going to invite our physicians up. If you can't stay, that's no worries. I'm going to actually try and answer some of these and send them out in an email as well. And so we'll just do a couple. I know you guys have to get going, and I appreciate everyone for coming, and hopefully you can spread the word so people can kind of be aware of this material. So this seems so formal. Okay, so one of the questions that I thought was great, and sorry if I don't ask your question, we'll certainly try to get to it and email it out. And if you have more questions, give them to me. So the first one, just with OIT, why do we not offer it at our clinic? And I guess, Sean, you can kind of answer this as our chief.
So the reason that we don't have OIT in the clinical practice is there's a variety of reasons that actually go into that. The first is that it is still effectively a research procedure at this point. It's not FDA approved, so there's no product. Now that may change in the relatively near future, as there are companies that are developing defined peanut products. So you may get some FDA approval there coming on. But the bigger issue for us is that because it is still a research procedure, we have the Sean Parker Center here that is doing research, and so we think that we should leave the research to them. Additionally, there are logistic reasons, and for some of the reasons that were mentioned in the talks here, you really want to be sure that when you're doing this procedure that you have a lot of backup, because it is complicated. There's a lot of questions that happen, and there are reactions that happen and can happen at any time during the desensitization process. So you really want to be able to have somebody who is you can reach at a moment's notice, any time of the day or night, 365 days a year. And right now we are not good enough about that to make that, I think, effective. We have a lot of patients that are coming through the clinic already, and we just don't have logistical space and that to do that. So those are the main reasons that we are not offering it right now, is the combination of that. And also because I do feel like there are still issues to be resolved with it, right? A relatively high rate of side effects that are associated with it. And also a lot of people choosing, even after having gone through desensitization protocols, to actually abandon the desensitization after they've gone through all that work and go back to strict avoidance. The rate of that was really quite high at least in some centers. So I think that it's a procedure that is probably very useful for some specific individuals, particularly if you have very severe reactions or have a lot of trouble avoiding the food. You might do very well on OIT, and it might be worth it. But if you don't fall into that category, I think you do have to think carefully about whether it is worth the logistic effort and expense that you go through to do it. So that's the basic reasons that we don't have it in the clinic at Stanford right now. But we do have it available in the research side of things, and there are providers in the community that are offering to you if you do decide that that's the right thing for you after discussing it with your allergist.
Yes, Dr. Dornbaum, is it anaphylaxis if the child's hands swell and he is crying in pain but has no breathing difficulty? And what would you do?
Well, if you think about it this way, if you ate something by mouth and you're having a reaction in your hands, it means you're having a generalized reaction. You're having a reaction that is involving distant parts of your body, of the GI tract. I would be inclined to use epinephrine in that case myself, and be on the safe side.
Yep, perfect. And then I guess Becca could answer this, or I had it over here. Oh, should we stop giving an allergenic food if the only symptom that they have is their eczema worsening?
So at this point in time, if the only symptom is a flare of the eczema, and there are clearly no hives or other sign of an IgE-mediated reaction, at this time our center, anyone else can back me on this, suggests that you keep the food in the diet.
My personal experience is that often it's not related. Very often you tend to remember the days when the eczema looks worst. And you tend to remember the time you ate the food near those days when you were worst. But when you do a real clear diary of what foods you're eating and how bad the eczema is, often what you find is that it's a hit and miss thing. And you know, the day that the eczema flares and it looks very bad is the day that you start thinking, oh, what did I eat in the last 3 or 4 days? And invariably that food comes up. So my experience is that there is usually no relationship. There may be rare cases. I've had a few cases where a patient had a very clear situation where he would eat one food and 2 days later the eczema was really bad. And we did it back and forth several times, and when we tried it several times, and it did happen several times, the family decided, I'd rather not give this food because it kind of controls the eczema better. So I don't think there is a hard and fast rule, but in most cases you will be able to eat the food. In a few you might need to avoid it.
Perfect.
I would add just one more thing there, which is that when foods have been removed in the past from the diets of children who have eczema, there has been pretty clearly shown in it that you do run some risk of converting what was a reaction that was only causing eczema into a reaction that is now IgE driven and may cause anaphylaxis. So it's quite well described that, for example, removing milk from the diet to try to control eczema. The kids were tolerating milk before. They may have had their eczema, but they were drinking milk and not having an issue. And then when milk was reintroduced several months later, they actually started reacting. And there was one actually well-described case report of a teenage girl who removed milk from her diet because of eczema. And within less than 6 months, she was reactive to milk. And much later on, she actually had an accidental milk exposure and died from that exposure. So I just share that as by ways of saying that it's not a trivial thing to take a food out of your diet, to really completely take a food out of your diet. And so you do want to think carefully about when and why you do that, because it's because there are consequences that you might not entirely appreciate from doing that. And eczema, I mean, everyone would love to be able to say, well, to have a diet or something so you don't have to put the creams on all the time, every day, like twice a day. It's a lot of creams, and everybody hates it. But when you think about eczema, eczema is something that we can treat. And we actually even have some newer therapies that are coming out for eczema that look really good. But food allergy right now is not something we can treat, at least not very easily. So I'm very careful about taking the food out of the diet in kids who are only having eczema because of that risk of transitioning it to a more serious allergy that is not able to be treated. So you're treating a disease that you can treat medically for one that you can't.
Perfect, thanks. And then do you have any statistics on whether a child what the chances are of a child outgrowing a food allergy when they're diagnosed early, whether it's a milk or peanut?
So roughly speaking, there's about a 75 to 80% chance that a child will outgrow a milk or egg allergy. The data is a little bit old, and it may be a little bit worse than that now. But there's about a 75 to 80% chance that a child will outgrow milk or egg allergy at some point in their childhood. Usually fairly early on, but even up to teenage years. The rate is lower in peanut allergies, but it's not non-significant. It's about up to like 20, maybe even 25% of children will outgrow a peanut allergy at some point in their life. So that is one of the reasons that it does make sense to keep coming back and looking at those tests and what has happened in the past year and those sorts of things to try and see if there really is still a peanut allergy there or not. Tree nut actually seem to be perhaps a little bit worse than peanut, and more like about 10% or so in terms of resolution. But tree nuts also haven't been as well studied, so I'm not entirely sure that number is hard and fast.
Perfect. And how often would you retest the labs if they have a diagnosed food allergy?
So it kind of depends a little bit on each individual patient and kind of how old you are, right? So if your child was tested really in the first, say 4, 6, 8 months of life, we'd probably recommend retesting sooner than say someone who's 3 or 4. But generally speaking, depending on the age range, somewhere in the realm of every year to maybe 3 years or so, maybe even a little bit longer than that in the older age. The data on your skin test or your blood test changing significantly from, say, a positive to then being resolved to a negative or being desensitized happens much slower than, say, if you were able to tolerate the food and had a negative test. You can become positive in what we think is a much faster way than, say, to lose that sensitivity.
Perfect.
I'd say in general practice, I tend to test kids that are very young, so under 2 years of age, that maybe have very low positive tests and more frequently. So some of those kids I may even test more frequently than a year, because a lot of those kids outgrow their egg and milk allergies pretty quickly. So my goal is to get it in their diet regularly as soon as I can.
Okay, so we don't have time for more, but I can certainly answer these in an email. And then these are the rock stars. They're the smartest people I know. So thank them for doing this and just taking time out of their day. It was really awesome. And they also happen to be flying out to the Quad AI conference in Orlando early tomorrow. Poor planning on my part. So just respect that, if you have questions or that sort of thing afterwards. And then, like I said, we have the video that we'll post and kind of give out to you guys. And hopefully we'll do this again next year. Cool. Yes.
I want to thank you to you because you organized everything.
Thanks guys. Thank you guys.